Hello everyone. Um, I am Abdel Salam Al-Askari from Egypt, and I welcome you all to this webinar. I particularly thank Dental XP for holding such a program, and I think it's something that is really incredible to provide some knowledge worldwide this way. I also would like to thank BioHorizons for supporting this event, for making this event happen. Today, my topic is discussing the complications that might occur with dental implants placed in fresh extraction sockets. There are many complications that occur with this treatment protocol. Although we know that dental implants placed in immediate implants fashion has a very predictable outcome and has reliable treatment results. Although we have these reliable results, we do have a lot of drawbacks and a lot of complications that might happen. It's a technique-sensitive procedure. Today, we'd like to talk about failures. I guess there's so much to be said for failures. It's much more interesting than success. This is my point of view nowadays. So let's just ask the question, why implant failures and complication rates has increased significantly nowadays? There are many reasons. The number one reason is that because of the total implant that is being placed has increased significantly from 37% to 56 or 57% this year. The number in the US, the number of general practitioners placing implants in is 4 times higher than the number in 2006 worldwide. The lack of comprehensive undergraduate dental education in dental implants is also a factor. More aggressive implantology procedures are being undertaken, like nerve repositioning, extreme grafting, and etc. And also, there are a lot of implant companies-based courses that do not focus on implant complications. They only focus on how to place the implant. Podium speakers, unfortunately, or it happens that they only show bright cases. They don't show a lot of complications. That's why we keep seeing this. The cases that you will see today, the clinical source of these complications that you see today is either from my educational programs that I run in my training facility here in Egypt, as well as some cases referred from colleagues, and my own complications that I am also having quite often. So let's just discuss those factors that would influence the outcome of any procedure. Let's, for example, say the regenerative procedure. Or maybe an regenerative procedure along with dental implants in fresh sites. The clinician is responsible. Either there is some technical errors, the technique itself is not used properly, or decision-making errors, like for example, is using a technique that is wrong to be used or not indicated. Or from the beginning, there is a diagnostic error either due to the lack of diagnostic tools that the dentist should have, or the wrong diagnosis. As well as poor patient selection that we all know, and I'm not going to go through this. Some patient inherit some systemic conditions that might be relatively contraindicated to the therapy, and I'm not going to go through this also. Intraoral conditions, chronic periodontitis, previously chronically treated periodontitis also happen. Available tissues, sometimes we do not have sufficient tissues available. Sometimes we do have sufficient tissues available. It's up to the condition that exists at the time of the diagnosis. Habitual factors. It happens to have a lot of detrimental effect on the patient. Smoking, for example, either happen, as well as alcohol drinking. Some risk factors added to these. There are some factors, for example, parafunction. Patients with parafunction are not contraindicated for implant therapy, but they influence the treatment. chronic periodontitis, especially previously chronic periodontitis patients, have probably high risk for failures. And tissue biotype, which we do not see quite often, people trying to distinguish between patients that have thin and thick tissue biotypes. High lip line for the patients, that would probably cause a lot of aesthetic effects. Consequences of the complications that might occur in the office to the patient. Patient mistrusts the dental team. There's always lists, recommendations, and referrals, frustrations, disappointed. We keep seeing all of these angry conversations, and sometimes go to legal issues, and we don't want to have that. This is from the patient side. From the dentist side, anxiety is being recorded in the literature. Depressive attacks is being recorded in the books recently, as well as poor focus with the patients, with other patients. The dentist is not able to focus on really what should be done to the other patients because he's so much in trouble with this complication. Unfair financial settlement, risk of medical legal issues that probably would be an event. However, it does not really matter if you experience failures or complications with dental implants or either regenerative procedures. All what matters is to inform the patient for any possible complications prior to the treatment. That's what we call patient preparation. I need to prepare the patient and I acquaint the patient with the possible complications in order to avoid it, in order to face it, frankly, with the patient later on. Now, definitely there are some benefits of this procedure. Placing implants in fresh sockets has benefits. One of the main benefits is immediate aesthetics. As you can see on your left-hand side, you can see a remaining root, a hopeless tooth, and you can see on the right side here a tooth. The tooth is being restored with dental implant. This is an incredible result. This is a 7 years now result, and it's extremely aesthetic. This is one of the real benefits of the immediate implant placement. Another benefit is that it's stabilizing the papillary heights. Usually, we don't have a real evidence from the literature on this, but you can see sometimes we do have, most of the time, we do have a stabilized papillary height, as you can see on your left and hand side of the screen. Also, we have optimal marginal tissues that looks natural. On the right side, on your left hand side, you can see this is the teeth to be taken out. And you can see when they are restored with dental implants, the harmonious shape of soft tissue as well as the bone support, and you can see how the case is restored. Definitely, the new technology of having laser etched surfaces like micro channels have added extra benefits on the stability of the margins of dental implants, and I will get through this in later on. Keys for success, and I would like really to comment on the keys of success here. It's very important to have success with dental implants placed in fresh sockets. Either, number one, identify the socket pathology, realize the socket pathology, and realize the socket morphology. And we go through this later on. Number two, socket debridement and cleaning. Optimal socket cleaning, lavage, is extremely important for the success of the procedure. Preserving the labial plate of bone and protecting the labial plate of bone and detecting the labial plate of bone is very important. Detecting, preventing, and then avoiding using wide implants in the aesthetic zone. We're no more using those wide implants anymore. I will show you later on the complications that would occur with using wide implants in the aesthetic zone. The use of cone beam CT has definitely added a lot of benefit to implant dentistry. I'm not going to discuss the benefits of cone beam CTs, but I'm not sure how many of us has a cone beam CT in his office. But we'll show later on some cases that really we needed those cone beam CTs to use. Implant primary stability and complete removal of the excess luting cement. Believe it or not, there is a lot of complications that occurs due to the residual cement that stays inside the crevice of the gingiva after cementation of the final or temporary crown. Now, let's go to complications. The most common complications is either because of faulty implant position. Some use this as an easy way. They have a socket, but unfortunately, this is what we can see here. We can see sockets that, after they heal, implants are totally placed in a bizarre area. And this is one of the drawbacks of the immediate implants. Although we have the socket as a guidance, but usually people slip the drill itself, slip off the socket itself into somewhere else. Or contamination of the implant from an infected site. As you can see here, this is a periapical infection. Sometimes we will go through this later on if we have some time, but some of cases had some failures because of this misjudgment on the condition of the pathology of this socket prior to placing dental implant. Also, the residual trapped cement could cause temporary peri-implantitis around the implants, and this is also something that is being recorded in the literature. Loss of the labial plate of bone and some apical tissue migration, and this is something that we really have to focus on, which is called, either you call it gingival recession, bone remodeling, whatever the name is, but this is something that we really have to focus on in the coming presentation. Now, let's identify the socket clinical condition. What are the socket clinical conditions that we have? We have a very simple, very, let's say, easy, and very nice divisions of socket. We have a type 1, type 2, type 3 socket. Type 1 is where you have soft tissue and bone, labial bone intact around the socket. This presentation, by the way, done by Stephen Chu and Ilian and Tarnow and Froome, and it's really people from NYU. Really, we have learned a lot from their knowledge. Type 2 socket, where you have soft tissue is intact and the bone, labial bone, is not intact. Type 3, when you have both are not intact and are insufficient, when you have lack of soft tissue and lack of labial bone. We can have subdivisions of these, but this is the way we do it. This is the way we work with it. It's easy divisions, easy classifications that we use quite often. Here is type 1 socket, which is everyone goes easy with. You cannot go wrong with this. Everywhere you go to presentations worldwide, you go to lectures, and you see bright cases, bright results. That's because it's being used for class 1 sockets. But what about class 2 sockets? What about class 3 sockets, for example? Now, let's see some work with class 1 sockets here. As you can see, the upper maxillary left central incisor is being discolored, and the right central incisor has some internal root resorption as well, and some staining. And we decided to take these teeth out, and this is the teeth after they've been taken out, and multiple apical ectomy and curettage has been done for this case. So we decided to take it out, and we wanted to get rid from this type of tattoo, amalgam tattoo that has been done previously. And this is the socket, and we went in, we placed 2 bi-horizons, laser micro channels implants, taper internal, and interestingly we placed an alloderm membrane sub-epithelially in order to mask this amalgam tattoo in this condition, just to make it more aesthetic. And this is just 1 week post-implant placement. Impressive, stains gone, patients are really happy. This is the case before, and this is the case after. Just mild staining remained, and I think I expect them, maybe some laser etching, maybe some laser resurfacing will probably will probably do very well for this case, and probably it's, I do not have a laser of myself. But anyway, complications now that occurs with class 1 type. The most important complication is the post-restorative labial tissue alteration. We call this gingival recession. This is a case you can see on your left side. This is for anterior teeth to be taken out. We replaced them with dental implants, and we put an 4 implant supported restoration. Beautiful result, but look down the road. This is 2 years down the road. This is what happened after 2 years. The soft tissue just creeped up, and we started to see this. I've been able to deal with this with a connective tissue graft. I've dealt with it okay. But why this happened? Why such complication occurs? Definitely it is because we are losing the underneath support, which is the labial bone. This has been documented by many authors, Botticelli, Danny Boozer, etc., Araujo, Lendi, many authors, and I will show you. This is one study by Botticelli. You can see that they stated in the conclusion that the horizontal resorption of the buccal bone dimension amount about 56%, and the corresponding resorption of the lingual plated bone was 30%. This is one study that indicated the loss of the labial plated bone. This is the famous 4 articles that being published by Araujo and Lendi, and you can see the amount of sections. This is an animal study. They lost this type of labial bone and lingual bone as well. And this is clinically, as you see here, this is an implant placed, and this is the slight discrepancy that we see down the road. So this is definitely something that we need to take care of. However, I have some concerns on that study. One concern is that there's no tissue type has been determined in this study. I don't see that they said that this is a thin scalloped tissue by type, thick, flat, whatever. Number 2 is that one-piece implants with polished collar has been used. It's not 2-piece implant. Number 3 is that they reflected buccal and lingual flaps in the same time, which induces more bone resorption. Number 4 is that root hemisection has been done, which might induce some resorption. That's why I have some concerns on that study. Another study, they also confirmed dimensional changes for the external socket walls after implant placement. There are some contributing factors that I would like to add to these studies. For example, tissue by type. If you have a thick labial plate of bone, definitely this reduces the chance of having soft tissue recession or bone migration. If you have a thin scallop tissue by type, your chances are, this doubles your chances or maybe triple your chances. That's why we need some studies that predict these 2 different types of biotype to see what really influences more bone resorption. Another contributing factor, as I said before, the color texture of the implant, the texture, and also the shape of the color. And I will focus with the texture first, using those type of new laser lock textures of the implant has been confirmed with some articles that being published with Nevins and others, and John Ritchie, and you can see there is a lot of evidence, histologic evidence on connective tissue attachment to the laser microchannels or microgrooves on the abutments or the implants. Now we have abutments that have microchannels that would probably lead to more stability of the soft tissue around the collar. Another contributing factor is the collar design. There is an article that being recently published that there are stress and strain distributions in the adjacent compact bone that is influenced by the implant collar design. The divergent implant collar design was associated with lowest stress strain concentration on the crestal bone, which subsequently would probably reduce or influence the bone resorption element. Another contributing factor is the platform switching. We have a lot of results. There is recently has been published a meta-analysis systematic review of over 1,000 literature that's being analyzed by someone from New Zealand. And this guy has published in recently the conclusion that platform switching may preserve inter-implant bone height and soft tissue levels. The degree of the marginal bone resorption is inversely related to the extent of the discrepancy of the implant abutment mismatch. So this is now, I do not think that, I cannot say that I have a valid evidence or a clinical sense of platform switching very much. It's just a personal opinion.